Everyone log on. Welcome. We'll be getting started shortly. Hello, and welcome to the webinar, Ways to Manage Ovarian Cancer Treatment Side Effects. I'm Maggie Nicholas-Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Now we're going to get into some housekeeping items. So all participants will be muted during the presentation. Once Courtney finishes presenting, we'll begin the Q&A discussion. Feel free to ask questions throughout the Q&A in the Q&A section at the bottom of your screen. Remember that Courtney is unable to give specific medical advice, so please keep your questions general. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to hand it over to today's speaker to introduce herself. Courtney, we're so excited to have you here today.
Thank you, Maggie. I'm excited to be here today as well. My name is Courtney Arn. I'm a nurse practitioner who works at The Ohio State University, James Cancer Hospital. I've been working here for almost 10 years, taking care of patients with gynecologic oncology conditions, including ovarian cancer. So I'm really excited to kind of go over some of these treatment options and most common side effects with you guys today, and hopefully give you guys some advice on how to manage these side effects. With that being said, oh, go ahead.
Yes, go for it.
I'm going to share my screen here. Okay, we are going to discuss ways to manage ovarian cancer treatment side effects. The agenda for today, first we're going to briefly go over ovarian cancer, and then we're going to talk about treatment options for ovarian cancer patients, and then we're going to talk about the most common side effects of those treatments, as well as how to manage those side effects. And then lastly, at the end, you guys will have an opportunity to ask me any questions. First, we're going to talk about ovarian cancer. The most common type of ovarian cancer is high-grade serous ovarian cancer or high-grade endometrioid ovarian cancer. However, there are several different types of ovarian cancer listed here. There's low-grade ovarian cancer, high-grade ovarian cancer, there's epithelial or non-epithelial. Your doctor will discuss this with you at the time after your surgery when they're going over the pathology, what type of cancer you have. And that's important to know for many reasons. It can affect prognosis, treatment options, things like that. So knowing what type of ovarian cancer you have is really important. Not only are there many different types of ovarian cancer, but that really the treatment options vary based on the type of ovarian cancer you have, as well as the different staging of ovarian cancer, which leads me to this next slide. The general timeline for patients who are diagnosed with ovarian cancer, first is surgery, including a hysterectomy and taking out both fallopian tubes and both ovaries. And then they also do a staging at that time. So surgery kind of serves two purposes. First, the goal is to get as much of the cancer out as possible, but it also helps give staging information, which helps identify how much cancer is there and how much it has spread, which can help determine the best treatment option for you and if you need chemotherapy or not. Some patients aren't a candidate for surgery at first for many different reasons, and they actually get chemotherapy before surgery. The reason for this is this chemotherapy can kind of shrink down the cancer to make the surgery more optimal, or maybe make it easier for them to be able to get more of the cancer out by getting the chemotherapy first. But in general, the timeline for ovarian cancer patients is first surgery followed by chemotherapy. There are many different chemotherapy options. The most common for ovarian cancer patients right after surgery would be carboplatin and paclitaxel. But because of different reasons, whether it's the type of cancer you have or any other medical conditions, they might recommend something different. There are platinum agents, including carboplatin and cisplatin. There's another class called taxanes, which would be paclitaxel or docetaxel. Doxil is another chemotherapy option. And the newer treatment for patients is called targeted therapy, which would include bevacizumab or mirvetuximab. For some patients with ovarian cancer, depending on their type of tumor, immunotherapy can be indicated, but not for all ovarian cancer patients. There's also clinical trial options for patients with ovarian cancer. And then oftentimes after completing chemotherapy, the oncology team will recommend maintenance therapy. What type of maintenance therapy or how long you're on maintenance therapy, again, depends on the type of cancer you have and the stage of your cancer. So in general, it's surgery, then chemotherapy, then maintenance therapy versus surveillance. If maintenance therapy is not recommended, or if chemotherapy in general is not recommended, you'll go into what we call surveillance visits, where you come into clinic generally every 3 to 4 months, oftentimes with the tumor marker, the CA-125, and sometimes CT scans with those visits, depending on the type of cancer that you have. And then some patients elect not to receive chemotherapy, and at that point, we'd recommend supportive care or palliative care, where we kind of shift the focus from recommending chemotherapy to treat the cancer to keeping you comfortable, keeping pain well controlled, things like that. So those are some of the different treatment options for ovarian cancer. Now we're going to talk about the most common side effects with those treatments. For the platinum agent, so again, this is the carboplatin or cisplatin. The most common side effects are nausea and vomiting, and then it could cause a decrease in your lab counts, including the anemia, which is low red blood cells, leukopenia or neutropenia, which is low white blood cells, and thrombocytopenia, which is low platelet count. When chemotherapy is given, it can't identify like these are good healthy cells versus these are cancerous cells. So it kind of goes through and wipes out all the cells in your body, which is what can cause some of these drop in the blood counts that your oncology team will be following before each cycle of chemotherapy. And with that can come some side effects that we'll talk about later. The platinum agents can also cause peripheral neuropathy, depending on the dose that you're given. Also, it's pretty rare, but it can cause nephrotoxicity, so it can affect the kidney or the renal function. So again, your oncology team will be checking labs prior to starting chemotherapy, and then prior to every cycle of chemotherapy to make sure that there haven't been a change in your lab values. And for this, the platinum agent specifically will want to keep a close eye on your kidney function or your creatinine level. It also can cause ototoxicity, which is it can cause tinnitus or ringing in the ears, or even sometimes hearing loss. This is also a little bit more rare, but something that you'd want to tell your oncology team if you're experiencing. And then with the platinum agents, there's a risk of having hypersensitivity reaction. With the platinums, it's usually the more chemotherapy that you've had. So usually after 5 to 6 cycles of having either the carboplatin or cisplatin, you are at risk of having a reaction to the chemotherapy. And your infusion nurses will talk to you about this, but if you have any change in your symptoms, like the most common with the platinum would be like itchy palms, red skin, rash, hives, itching, things like that, you'd want to let your oncology team know right away, because you can have a reaction to the chemotherapy. For the taxanes, the most common side effects are alopecia or losing your hair, and this happens pretty quickly. It's usually 10 to 14 days after the first cycle of your the Taxol, after the paclitaxel, after starting chemo. It also can cause diarrhea, nausea, and vomiting. Taxanes, just like the platinum agents, can cause a drop in the lab counts, so the anemia, neutropenia, thrombocytopenia, or low red blood cells, low white blood cells, and drop in your platelet count. These also can cause hypersensitivity reactions. Sometimes with this, patients will get chest pain, or they also can have the red skin, itchy palms, things like that. So if you have any change in your symptoms during your infusion, make sure you let them know. And then the taxanes can also cause joint pain. Targeted therapy, again, is that treatment that we were talking about that's a little bit newer. The most common for ovarian cancer are bevacizumab or mirvetuximab. They cause a little bit different side effects than the carboplatin or the paclitaxel. The most common with this is some GI symptoms, including abdominal pain, constipation, decreased appetite, diarrhea, nausea, vomiting. It also can cause the drop in the red blood cell count or anemia. And this one can cause an increase in the liver function test. It doesn't necessarily cause liver dysfunction, but there might just be an increase in the lab values of your liver function test. And again, your oncology team will getting these labs at baseline and then prior to every cycle of your chemo. Also can cause fatigue, neuropathy, or the numbness and tingling in your fingers or toes, joint pain, hypertension or increase in your blood pressure. And then the mirvetuximab can cause ocular toxicities, the most common being cataract, keratitis, dry eyes, photophobia, so like a sensitivity to light, or sometimes even changes in vision, like blurred vision or decrease in how far you're able to see. We'll talk a little bit more about this specifically later, but we'll refer to eye care provider and keep really close eye on patients who are receiving mirvetuximab because of this potential side effect. So now we are going to talk about the specific side effects and kind of ways that we can help manage them. One of the most common side effects of chemotherapy is nausea and vomiting. We've come a really long way. If you see any movies, I always tell my patients when counseling them their first visit, like chemotherapy is not like you see in the movies or on TV, but it did used to be. We didn't have nearly as many medication options when chemotherapy was first discovered and started treating patients with. And so we've definitely come a long way as far as preventing nausea and then also managing nausea for these patients. So the first step is prevention. So we give medication in the IV before getting the chemotherapy to try to prevent patients from experiencing nausea or vomiting. We also, for most chemotherapy regimens, have patients have nausea medication at home to try to prevent the nausea that they'll take for a few days after their chemotherapy, and then as needed if they're having nausea. So nausea medication can be taken more as a preventative measure, where you take it on like a scheduled routine to prevent having any nausea, or on an as-needed basis. If you're having nausea, you take the medication, and it usually works pretty quickly. Again, there's a lot of different treatment options. So if you take one nausea medication and you're still having nausea, or that medication's not working, or you're not tolerating it, make sure you talk to your oncology team, because there's a lot of different medication options out there. And they all work a little bit differently, and their side effects are a little bit different too. So if you're not able to tolerate one, don't give up and just think you're going to be nauseous. Our goal is for our patients to have very little nausea, and they should not be vomiting. So although it is a very common side effect of chemotherapy, it's something that usually we're able to prevent pretty well. And if you are experiencing it, you should be able to manage pretty well with medications. Aside from medications, there's supportive care that we can do too. If patients are having nausea, vomiting, we want to make sure you're staying well hydrated. If you're having trouble getting fluids down, or maybe drinking water or drinking fluids just doesn't sound very good because you're so nauseous, sometimes we have to bring patients in for IV fluids. And this not only kind of helps with the nausea, but also helps keep you hydrated if you're having nausea and vomiting, and keeps prevention from getting too weak or dehydrated. Diet is really important too, making sure you're following a bland diet. There might be certain foods that make you nauseous, just thinking about them or smelling them, or after eating them, you might not feel very well. So I always encourage my patients to kind of keep a food diary. If there's any specific foods they eat that they have noticed they get pretty significant nausea afterwards, and try to avoid those foods. Sometimes referring to a dietitian for this reason can be helpful too. They can go over different food options that can help reduce nausea. Small frequent meals is really helpful too. If you're eating small frequent meals, you're kind of able to get the calories and the protein in, rather than eating 3 big meals that can sometimes make the nausea vomiting worse. Or if you're feeling nauseous, a big meal is overwhelming and a little bit scary. So just eating little bites at a time, but more frequently, is a way to get that nutrition in. There's also some other alternative methods like breathing exercise or meditation that has been found really beneficial for patients who are experiencing nausea and vomiting too. So, and summary, it's really important to make sure you tell your oncology team or your provider right away if you start to have nausea and your nausea medication that you have at home isn't working. The sooner we start to intervene on this, the more likely we'll be able to get better control over the nausea and vomiting. So don't be afraid to reach out. If you don't intervene quickly, it can lead to dehydration, weakness, things like that. So definitely let us know right away if you're having not any nausea or vomiting, and make sure you're utilizing the nausea medications that you have at home. And if they're not helping, make sure you reach out to try something different. Neuropathy is another very common side effect of chemotherapy. Neuropathy, most commonly patients present with numbness or tingling or both in their fingertips or toes. Some people have it throughout their hands and their whole feet, but oftentimes it's just numbness and tingling in the fingers or toes. And this can present a little bit differently too. Some people have more of like a joint pain or a muscle ache in their hands or their feet, or even their legs and their hands or arms. Other people can have just like a weakness, like they used to be able to open jars easily. Now they find that they're having more trouble with the strength in their hand with opening jars or going up and down the stairs. So if you notice any of these symptoms while receiving treatment with chemotherapy, you want to make sure you let your provider know. Sometimes your chemotherapy needs to be held or dose reduced depending on the severity of the neuropathy. Physical therapy has also been found to be really helpful. They can teach you different exercises to help with that numbness and tingling. They also can make sure that you have the resources you need. Sometimes patients have, numbness and tingling in their feet so bad that they're unsteady on their feet and require a walker. And so we want to make sure that you're safe, not having any falls, but definitely, pay attention for those symptoms. Let your provider know if you're experiencing any of that. There's also medications that can be used that can really help, not necessarily prevent the numbness and tingling, but if you do start to develop it, they can give it to help minimize those symptoms and prevent it from getting worse so that we're able to continue the chemotherapy. If you develop the numbness and tingling, obviously make sure that you're ambulating carefully. Make sure you don't have any rugs in your house that you could easily slip over because it can impact your ability to walk or like your balance. And then also you want to let your provider know if you're having any trouble like buttoning things, zipping things. Some women say that they are having a hard time putting their earrings in. If it starts to get to be that bad, you definitely want to let your provider know because again, they might need to hold or dose reduce the chemo. But there's also other interventions that we can try to do before just jumping to that. Fatigue is also a very common side effect of patients who are receiving treatment with chemotherapy. This one is a little bit more challenging to manage and treat because it's very much relying on the patient to explain how bad it is and how much it's impacting them. And so I usually kind of ask patients, has there been a change in your activity level? Like, are you sleeping more throughout the day? Are you resting more? Are you still able to do your normal daily activities like showering, cook your own meals, those types of things? And everyone's baseline's a little bit different too. So it's important, before chemotherapy, how active were you compared to now? There's some people who are really, really active, so they're still able to do those things, but there's still been a pretty significant change in their energy level. And that's important to note. So make sure, you're letting your provider know if you're noticing an increase in fatigue or a change in your activity level so that they're seeing how much it's impacting your quality of life. There's several different interventions we can do to help with fatigue. One of the most common or most important ones we can do, and it's easy, is exercise or physical activity. So it doesn't require medications, referrals. It's just something at home that you can do. And it doesn't have to be going to the gym for 30 minutes a day and lifting weights. It can be, going for a walk. Going for a walk is great for mentally and physically. It kind of helps with the fatigue, but it also just makes you feel good, gets those endorphins going. So don't underestimate the importance of physical activity or exercise, and also don't let that, scare you like, oh, I'm so tired, I can barely like sit up, let alone exercise. It doesn't have to be, any crazy exercise routine. It could be even sitting in a chair and kind of lifting some arm weights or moving your legs around. Or I even tell my patients like every hour, just kind of get up and walk a little bit in your living room. Those types of things will really make a big impact on how you're feeling. Now, there might be days where the fatigue is so bad that feels impossible and you're not able to get out of bed or off the couch. And listen to your body, and that's okay to have those days every once in a while. But sometimes the more you're resting and laying down, the more that can cause some fatigue too. And that's a little bit of a vicious cycle. You're more tired, so you're not doing as much, and then you get more tired. So don't be too hard on yourself, but definitely try to get some type of physical activity in if you're experiencing fatigue. Diet also plays an important role in this too. If you're eating, bad food that's making you feel kind of lousy, that can definitely impact your overall energy level. So make sure you're getting nutrition in, lots of protein, lots of water. That can really make a difference in how you're feeling overall. Dehydration is one of the most common causes of fatigue too, so make sure that you're getting plenty of fluid intake if you're having fatigue. Physical therapy also really helps with fatigue. I know I've mentioned that for almost every side effect so far, but it really does make a big difference getting that physical activity in. And physical therapists are kind of able to identify different exercises for you to do. There have been studies that have shown that patients who do physical therapy while receiving chemotherapy tend to do better with their chemotherapy treatment, like their tolerance. I'm not saying like respond better to the chemo, but they're able to generally like feel better while receiving treatment with chemotherapy if they're undergoing physical therapy. Especially for those patients who are getting chemotherapy before surgery, we want to make sure that you're, staying healthy, staying physically fit prior to going to a surgery. So ask your oncology team for a referral to physical therapy. They can work with you on different exercises to help with not only fatigue, but many of the other common side effects. There's also integrative therapy, which includes yoga, acupuncture, meditation, and Tai Chi. And the meditation and yoga you can do on your own at home. If you have videos you want to watch, have different exercises, that's fine too. But there have been a lot of studies that show yoga, meditation can positively impact the amount of fatigue that you're having. Some patients swear by acupuncture and Tai Chi also. And so if you need a referral to integrative therapy, those are some alternative options to help with the fatigue. You also want to make sure that we're treating the cause. So if you're having a lot of pain, that could certainly contribute to fatigue. Or if you're having a lot of nausea and not eating and drinking very much and get dehydrated, that can also cause fatigue. Oftentimes, some lab values can be abnormal too. We talked earlier about like the drop in white blood cells, red blood cells. Those can impact your energy level and they can make you a little bit more fatigued. So if you're having fatigue, obviously we want to make sure looking at the whole picture, like, is it because you're having so much pain and you're not up moving around as much and you're taking so much pain medicine that's causing the fatigue? Let's get the pain under control and then start working on the fatigue. That ultimately will help with the fatigue. So make sure we're treating all the other causes that could potentially be contributing to the fatigue. And also make sure we're not missing something else like infection or something else causing the fatigue. It's easy to kind of blame the chemotherapy for all these things, but sometimes there can be other things that are contributing to it as well. There are also some medications. One example is like a stimulant that can help with fatigue. Talk to your provider about that. If you've tried physical activity, modifying the dose of your chemo, all these other things, and nothing seems to be helping, I do think it's worth talking to providers about if there's a medication that can help with your fatigue or energy level. Hematologic is another common side effect of chemotherapy, the most common being anemia, neutropenia, and thrombocytopenia. Anemia means low red blood cells or low hemoglobin. Oh gosh, I'm sorry, hold on. And so again, your healthcare providers will be checking labs at baseline, and then they will also be checking them prior to each treatment. If there's been a significant drop in your count, or if it drops below like the normal value and they think that they need to intervene, the most common intervention for anemia or the low red blood cells is a blood transfusion. And so they would get you set up for a blood transfusion. The anemia can also lead to significant fatigue too. So not only do we want to keep your blood cell counts normal, but it also will help you feel better getting the blood transfusion too if it's indicated and if that lab value has dropped low enough to need a blood transfusion. Neutropenia is low white blood cells. There's nothing that you can do to prevent these from dropping. Again, the chemotherapy just kind of wipes out all those good healthy cells as well. And so keeping a close eye on the lab values. And then if you're having count issues toward your white blood cell counts aren't recovering by time it's due for your next chemotherapy, sometimes oncology teams will recommend granulocyte colony stimulating factor, or they'll refer to it as CSF. And it's like it stimulates the white blood cell counts to kind of boost them up. This can be given before chemotherapy sometimes to get the counts high enough in order to give chemotherapy, or it can be given after the chemotherapy to prevent those white blood cell counts from dropping so low after getting the chemo. And this serves as a couple purposes. Number one, it kind of helps prevent delaying the chemotherapy, because if your white blood cell counts are too low, we're not able to give chemotherapy. And so by boosting them with this growth factor, it can sometimes prevent the delay in chemotherapy or dose reduction. But it also helps prevent getting an infection, because if your white blood cell counts drop too low, you're at a higher risk of infection. And so we don't want them dropping dangerously low to where you're high risk of infection. Being on chemotherapy in general, can increase the risk of infection because your lab values are a little bit lower than normal. But if they get too significantly low, even higher risk of infection. And so sometimes the growth factor will be recommended for those two reasons. And then lastly is thrombocytopenia or low platelets. Platelets are the clotting part of your blood. And again, the chemotherapy just kind of goes in and decreases these blood cell counts. And when doing so, it can drop the counts of platelets. And so if your platelet count drops too low, sometimes your provider will recommend a platelet transfusion. This isn't nearly as common as the blood transfusion or the low white blood cell counts, the drop in the platelets to where you need a platelet transfusion, but sometimes can happen. Just like the white blood cell counts, if your platelet counts are too low, your oncology team might call you and say, hey, your lab values aren't high enough for chemotherapy today. We need to delay treatment. Again, there's nothing that you did wrong. There's nothing you can do to prevent this. It's just a common side effect of the chemotherapy, and we want to allow those to return to normal values before we give another dose of chemotherapy to be safe and prevent them from dropping too dangerously low. One of the last side effects we'll talk about is ocular toxicity. This isn't very common with most chemotherapy agents, but with one of the newer treatment options for ovarian cancer, which is called mirvetuximab, it can cause ocular toxicity. Again, the most common are keratitis, which is like an inflammation of the cornea. It can cause conjunctivitis, which is almost like a pink eye. It can cause blurred vision, sensitivity to light, and it also can affect how far you're able to see. So if you're started on treatment with mirvetuximab, prior to starting treatment, you'll see an eye care provider. It can be an optometrist or ophthalmologist. They'll do an eye exam to make sure that there's no eye conditions that would prevent you from being able to receive treatment with mirvetuximab. They'll check your visual acuity, meaning they'll see how far you're able to see, so that every time you come in after getting the treatment, we can make sure there hasn't been a significant change in your vision. There's also eye drops that you use to try to prevent these ocular toxicities from occurring. So before ever getting treatment with mirvetuximab, there would be eye drops that you would be using at home. And then you use them for 8 days after your treatment as well. And this significantly reduces the risk of having any ocular toxicities from the mirvetuximab. And you'll see an eye care provider prior to every other cycle. And so they'll be keeping a close eye on your eye exam to make sure there haven't been any changes, but also you would need to report if you've noticed any changes in your vision or new ocular symptoms. Patient education for this is really, really important. So your pharmacist, oncologist, nurse, someone will be going to go over the most common side effects with you. They'll talk about seeing an eye care provider. They'll talk to you about the eye drops, things like that. But definitely let your eye care provider know if you're having any new eye symptoms while receiving that treatment. And that's it. So I heard there's some questions. We can start going through those now.
Great. Thank you so much, Courtney, for that awesome presentation. We can definitely get the Q&A started. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. So this first question is about whether it's possible to develop a reaction to carboplatin after several doses.
Yeah, so it's actually there's two different types of reactions. One is the more of the chemotherapy you've gotten, the higher risk of reaction. And then the other types of chemotherapy, it's the first cycle or second cycle, because your body hasn't really been exposed to it yet. And it's kind of like, what is this that you're giving to me? Carboplatin is the first one I mentioned. The more you have gotten of it, the higher risk of having a reaction. So we generally don't see a reaction to the carboplatin until after cycle 5 or 6. But it can happen earlier, but generally it's after at least 5 to 6 cycles. And then, if cancer comes back and you get carboplatin in the future, getting it that second time is the highest risk of when you're going to have a reaction. Also having a large window in between there. So say you got 6 cycles of carboplatin and then several years go by and you get carboplatin again, that first or second cycle after restarting is when the highest risk of having a carboplatin reaction would be. Now,
And is there any,
paclitaxel is much different. It is the first or second cycle that it happens, and then we kind of get your body used to it, and then it doesn't usually recur. So just because you have a reaction the first or second cycle doesn't mean that we won't be able to continue to give the paclitaxel.
and is there anything patients can do about that, or are they just nothing?
Everyone's body just kind of responds to it a little bit differently. There's nothing we can do to prevent it. We're kind of looking at different ways, like are certain patients based on certain things a higher risk? We do know that patients who have a lot of allergies are a little bit higher risk of having a reaction to the chemotherapy, but there's nothing specific that patients can do to prevent that from happening. But the nurses are very experienced with these types of things. They respond very quickly. And generally, we stop the chemotherapy infusion, whichever medication you're reacting to, give some medications, and then the reaction usually stops pretty quickly after that.
Okay, thank you.
Mhm.
And so this person is asking about they're having severe indigestion from olaparib, but they can't take omeprazole because of their kidneys. Do you have any suggestions of other things they could consider?
Yes, there's a lot of different medications for acid reflux. If not able to tolerate omeprazole, Pepsid sometimes work. And then also Protonix is another option too. I don't know specifically if those are okay, based on your medical history, you know, so of course run it by your oncology team, provider, pharmacy, things like that too, to make sure that those will be okay. But there's a lot of other options. Diet is really good too. You want to make sure that you're doing a bland diet, sitting up for 30 to 60 minutes after eating. But there's definitely other medication options out there too.
Great. And this person is asking about what medications are available for neuropathy other than gabapentin.
Yeah, I actually really like prescribing duloxetine or Cymbalta. It's actually an antidepressant medication, but it works really well. I start at kind of a lower dose and then titrate up. It works well for like the numbness and tingling. It also works really well for joint pain. And then I think there's an added benefit of lifting the mood a little bit too. I think anybody going through chemotherapy or cancer diagnosis could use an antidepressant. So while we're not necessarily prescribing it for anxiety, depression, I do think it has that little added benefit too. There's also Lyrica, a lot of people will use for the neuropathy too, but I usually do the duloxetine.
Great. And then we have a couple of questions about tinnitus. So what can people do about it? And also, if it's very mild, should you still see an audiologist?
Kind of depends on the, you know, severity and how much it's impacting your quality of life. If it's very, very mild, intermittent, not very impactful on your hearing, quality of life, then I think it's worth just monitoring and making sure keeping close eye on like the chemotherapy dosing, that type of thing, if we need to switch to a different medication. But I don't think it hurts to see an audiologist because they can do a formal exam, make sure that there hasn't been more of an impact on the hearing too. You might not notice it, but you could be having some hearing impact too based on the tinnitus. So never wrong to refer to an audiologist. If it's mild, intermittent, I usually defer doing that until it gets more significant, but there's never a wrong time to refer to an audiologist if having the tinnitus.
Great. And can you talk more about managing the side effects of bevacizumab, specifically kidney function and high blood pressure?
Yes, so bevacizumab can affect kidney function. It also can cause some protein in the urine. So those are the two, like the lab values in urine that we would want to closely monitor while receiving treatment with bevacizumab. As far as the kidney function goes, if there's a elevated in the serum creatinine or there's a lot of protein in the urine, then I would generally refer to a nephrologist and have them help manage. They kind of help dictate, you know, is it okay to continue bevacizumab or should we hold It seems to be accumulative with the kidney function, so it's not something that happens right away, but more like the more you get of it. So sometimes you have to have the discussion, it's starting to affect the kidneys. Should we stop treatment with bevacizumab or continue? And then as far as the blood pressure goes, definitely prior to starting treatment with bevacizumab, want to make sure you have blood pressure well controlled. So a lot of our patients, they're battling cancer and haven't had time to go see primary care doctors. There's enough visits with this. So some patients have like a baseline hypertension that has been either undiagnosed or not well controlled. So prior to starting treatment with bevacizumab, make sure the blood pressure is well controlled. If they're on blood pressure medication, make sure it's a high enough dose. If there starts to be an increase in blood pressure with the bevacizumab, optimize. I usually fully go to the full maximum dose of whatever blood pressure medication they're already on, if they're on one. But if that's not controlling it, adding another agent. Usually after I have to add 2 to 3 agents, that's when I would refer to a nephrology team to have their assistance with helping manage the blood pressure. And then giving very strict precautions, making sure all of our patients have a blood pressure monitor at home and then they're keeping a log. And then I usually have my patients bring their log in with them or send me in my chart so I can kind of see. Sometimes when coming in for visit, their blood pressure is elevated because they're nervous and anxious for their visit. So I like to be able to see what their blood pressures have been at home to get a better capture of like exactly how their blood pressures are running.
Great. And I see another question just came through about bevacizumab, and this person's asking if shortness of breath could also be a side effect of that.
It's not a common side effect of bevacizumab, but there are different things that bevacizumab could cause that could be causing the shortness of breath. My first thought, is like you want to always my first go-to is always make sure it's not cancer related. And, there could be like fluid in the lungs from the cancer causing the shortness of breath. If you're having really high blood pressure, that can cause shortness of breath. Bevacizumab rarely can affect like cardiac function. So you want to make sure that's not something cardiac relating causing the shortness of breath. So there could be other causes indirectly related to the bevacizumab, but it's not a common side effect of bevacizumab.
Great. And we're getting a couple of questions about anemia. This first one is about, I think they're asking like the need for and use of iron with, like, I guess the role of iron in managing anemia.
Yeah, every provider has a different opinion on this, but I do think iron can help maintain that hemoglobin. Chemotherapy can pretty significantly drop the hemoglobin pretty quickly, and so sometimes the iron feels almost like it's not doing anything, but I do think that it can kind of help maintain the hemoglobin. Sometimes people are taking iron and they still have a big drop in their hemoglobin after getting chemotherapy, regardless. But if you do take iron to kind of help maintain that, just know that it can cause constipation. So make sure you have a good bowel regimen. And then it can make your stool like a black tarry color. So be mindful of that and be prepared to see that. But if the hemoglobin drops significantly, oftentimes you'll need actual blood transfusion. But if it's just kind of stable but staying a little bit lower than normal, an iron supplement is a good option.
And what about ferrous gluconate?
That could be a different type of iron supplement too.
Oh, that is an iron supplement.
Yep. Again, just make sure, you're checking with your oncology team and make sure there's no reason that you couldn't be on iron.
Okay. And then what about when, suggestions for treating anemia when the labs are normal and iron supplementation has not improved the levels?
If the hemoglobin is normal, then I would not recommend a blood transfusion. But if the hemoglobin is dropping and you're on iron and it's not improving, then would recommend a blood transfusion. Okay. Every institution's a little bit different, and with COVID, there's been a blood shortage. So some providers recommend a blood transfusion if the hemoglobin is less than 8. Some wait until it's less than 7. I really just kind of like go, base mine off patient symptoms. If they're really symptomatic, having a lot of fatigue, shortness of breath can also be a side effect of anemia. Then even if it is a little bit higher than I generally give a blood transfusion, if they're having those symptoms, I'd be quicker to give a blood transfusion. Some people have a hemoglobin less than 8 and they feel great and they don't want blood, and then we just closely monitor it.
Great. And then we have some more questions about neuropathy and specifically how to deal with it in the feet. If you have any suggestions for that.
Really recommend the physical therapy, even massage therapy. Patients have had good results with having massage therapy for their feet to kind of help with that circulation. There's no data to support it. I think there's been like one really, really small clinical trial, but some people have put ice on their feet while getting a chemotherapy infusion to help reduce the risk of neuropathy. It's not something I generally like recommend because I haven't seen the data to support it, but I do know some people like to do that. The medications that we talked about earlier are really, really helpful. It generally seems to be as soon as they start some of those medications, they see improvement in their neuropathy right away. There's also been some patients who've tried like Voltaren gel, which is a gel that you can get over the counter to help with some of that like achiness in the feet. And then some patients have used different oils or like even a CBD oil to help with the pain in their feet. Keeping your feet not too cold but not too warm is helpful too. Some people have a big flare up of their neuropathy if their feet get too cold or too hot, or some people feel like their feet's like burning on fire, so keeping it a little bit cooler, or some feel like they're like really, really ice cold, and so keeping their feet warm with socks is helpful too.
Great. And then what about dealing with bone pain? Is there anything that can help that?
The physical therapy, massage therapy, some of the integrative therapies can help with that too. Exercise. Some people, heat is the best thing, like either a hot shower, heated blanket, heating pad, things like that can really help with the bone pain. Claritin as an antihistamine, for some reason, that seems to help with the bone pain too. And then the duloxetine I usually prescribe for bone pain. It really helps with that.
Great. And then suggestions for dealing with constipation beyond diet and fluids.
Yeah, I guess we didn't talk much about constipation. That's a really common side effect of chemotherapy as well. I know you said beyond fluids, but fluids is one of the most common things you can do. So the first week after chemotherapy is when the constipation is the worst. And it's also when you're not feeling great, not always wanting to drink fluids. So really pushing those fluids. If you've found that, you get constipated after each cycle of chemotherapy, I usually recommend like a scheduled bowel regimen before even getting the chemo. So the day you're getting chemo, start taking a stool softener every single day and for at least a week after, if not daily, the entire time you're on chemotherapy. There's two things that you can do for constipation. One of them is a stool softener, which helps makes the stool soft. So you want to make sure you're taking that softener. And then there's a lot of laxative options out there. They're more of a stimulant. So the stool softener makes it soft. The stimulant makes you go. But if you just take the stimulant by itself, it makes you go. But if your stool's too hard, it's not going to pass through. So you want to take them together. A lot of the stimulant, there's a lot of different stimulants. There's Miralax, milk of magnesia, Senna, and it's kind of patient preference. The Senna is a pill form. The Miralax is a powder form. The milk of mag you can take every 6 hours. So it's combining the stool softener and the laxative together to keep the bowels moving. And it's being proactive, not waiting until you get constipated. But if you know you get constipated after every chemo treatment, start that bowel regimen before you get constipated to keep things moving. And then it's much, much better tolerated if you're able to get ahead of it before it becomes a problem. But fluids too is really, really helpful. And then if those types of things fail, there's always like laxatives or enemas or suppositories too. But usually the combination of the stool softener and the laxative and taking it proactively before it becomes an issue after the chemo is beneficial.
Great. And then this person is wondering if you've seen a difference in side effects in patients who do a fasting protocol around treatment days, and then or using high dose IV vitamin C. So a two-part question.
Yeah. There are a lot of patients who feel that fasting before or after their infusion can help with their response because it's kind of starving the tumor and the chemo is going right to the tumor. There have not been any clinical trials to help support that. But I do think, it's important if that's something that's important to the patient or they feel like is beneficial, but it's not something I usually recommend. I don't like to recommend anything unless I've seen evidence to help support it. But I do think that diet in general is good and making sure that you're making good, healthy choices can have a positive impact, not only on your overall health, but kind of how you're feeling while getting the treatment. Whether or not it makes a big difference on your response to chemotherapy, that's what we're still trying to figure out.
Mhm.
The high dose vitamin C, again, we don't have any data to support that. I wish, we're
Mhm.
constantly looking for new treatment options, things like that, but there hasn't been anything to support that. And in
Mhm.
fact, sometimes doing high doses of any type of supplement can interfere with the chemotherapy. So I'm not saying that, you guys can't choose that as an option, but if you're doing chemotherapy, you need to make sure that your oncology team is aware that you're taking supplements or high doses of anything, to make sure that there's not an interaction with your chemotherapy.
Mhm. Great. And we just got a follow-up question, asking if you could give some examples of stool softeners.
Yeah, the one we usually use is docusate sodium or cholase, and you can take that up to 6 times a day. So again, if you're just having a little bit of constipation intermittently, I usually recommend just taking that once a day, every day to keep the stool soft. If you are, for 3 days after chemotherapy, really, really constipated and then having normal bowel movements after that, usually recommend being a little bit more aggressive and taking it twice a day right away, and then take it for, 3 to 5 days after chemo to try to prevent it. But it can be taken on an as needed basis. So if you're constipated, take it a couple times that day, see if it works, or on more of a daily, like once a day or twice a day, every day to keep bowels moving.
Great. And so this person is asking, how can you manage nails lifting from the nail beds, because of taxanes?
Yeah, so the taxane, it's rare, but it can cause changes to the nails. Some are just appearance where you can have like a little bit of like a dark end underneath. Some actually have lifting. We usually recommend soaking them in baking soda water mix, like a warm water. Sometimes Epsom salt can help, but definitely let your provider know if they start to lift. But soaking them in those waters can usually help. They can also kind of crack or chip a little bit too. So keeping your nails cut back short, just right above the palm of your hand or the fingertips, can help prevent that like cracking, pulling sensation too. But soaking them in Epsom salt or baking soda water helps. And then if there's any signs of infection like redness, sometimes you can even have like a pus draining from out of there, or like fevers, or your fingers are warm to touch. You want to let your oncology team know right away.
Great. And what about, I'm not sure we touched on this, but acupuncture for neuropathy?
Yeah, it's definitely an option. I don't know if there's been a lot of data to support it, but I have had patients who have gotten acupuncture through the integrative medicine referral, and that they have had improvement in their neuropathy. I've had other patients who did it and didn't like it or didn't see improvement. So it's kind of varies among my patients. But I think if either you're opposed to doing medication for the neuropathy or you've tried medication, it's not helping, I do think that it is an option. Again, I don't know the success rate of it or the evidence
Mhm.
behind it, but I do know that some patients have had improvement in their neuropathy with the acupuncture, as well as improvement in their nausea or fatigue or other things like that too.
So it sounds like there isn't harm though in trying it.
No,
Mhm. And
as long as you don't have any other like medical conditions that would like prevent you from getting acupuncture.
mhm. Right. And then, could you talk a little bit about, suggestions for managing memory problems? We haven't talked about that as much.
Yeah,
So like
it's
chemo
not
brain
one
and,
of the common chemotherapy side effects, but it certainly can happen. It seems to be accumulative. The more chemotherapy you've received, it can actually cause some memory changes or quote unquote like brain fog. And it's a real diagnosis. Um, I think that it's something that is hard for us to identify or diagnose because the changes in the memory could be many things. It could be fatigue or not feeling well, or aging, that can sometimes happen too. So I think really kind of investigating what we think is the cause of it and then referring as appropriate. There's behavioral therapy, there's neurology that you could refer to kind of do like a more of an assessment to see if there has been changes in the memory to better identify like the best treatment option for that. Things we recommend is like keeping the brain stimulated, so like crossword puzzles, word searches, things like that. So you're constantly keeping your brain going. Eating well-balanced diet, getting your physical activity in, those types of things tend to help too. But also referring when needed to if there has been a significant change in memory, because it's real. I think a lot of
Mhm.
people feel embarrassed or they think like it's not a real side effect of chemotherapy, but it can cause changes to memory, and it is
Mhm.
a real diagnosis, and it does deserve, to be treated, managed, those types of things.
Mhm. Great. And this person is asking about the impact of treatments on the bones and related conditions such as osteoporosis.
Yeah, specifically for low-grade ovarian cancer patients who are on a anti-hormone therapy. So some cancers are kind of driven by hormones. And so a treatment option for them would be to kind of take those hormones away. And those types of patients are at higher risk of getting osteopenia or osteoporosis. Or if a patient had a hysterectomy at a young age, that could also significantly increase their risk of having bone loss or the osteopenia, osteoporosis. And then female in general, without any of those things, are already at high risk of developing osteopenia, osteoporosis. And again, a lot of our patients aren't going and getting their routine health maintenance because they're, focusing on their cancer diagnosis and cancer treatment. So generally, for the general population, they don't get bone scans until after the age of 65 and then every 2 to 3 years. But for our patients, if they have hysterectomy at young age or they're on chemotherapy agents that can affect bone loss, we recommend getting a bone mineral density scan every 2 years and closely monitoring that. Some oncology teams order that and manage that. Others refer to either endocrinology or primary care to be ordering those, but it is important to get those bone scans every 2 to 3 years and then also make sure you're taking calcium and vitamin D as well.
All right, great. And so I know that this could be its whole topic, and we do topics, we do webinars and programs on this, but could you give some tips on how to manage painful intercourse post radical hysterectomy?
Yes, that's another thing that I don't think we talk enough about. It's not specifically a side effect of chemotherapy, but it can be, especially if you're on one of those anti-hormone therapies that also, takes that hormone out, so it can increase the risk of vaginal dryness and pain with intercourse. The number one thing I usually recommend first is using a vaginal moisturizer. There's a lot of them that you can get over the counter, but that just kind of helps moisturize the tissue. So having a hysterectomy, being on chemotherapy can kind of cause some vaginal dryness. So keeping that tissue more moisturized can really help with the pain with intercourse. You also want to make sure that you're using lubrication during intercourse. And sometimes that's enough. Sometimes people don't have to use moisturizer in between, but I think the combination of the two is best. So using the, moisturizer every other day or a couple of times a week, and then the lubrication during intercourse. You want to do a water-based lubricant. Some patients like to use coconut oil as like the moisturizer, but make sure that the lubrication is water-based, and applying it before having intercourse. Also, making sure that the position is comfortable for you. So you might be able to do some positions, but not other positions. So just make sure you're having that conversation with your partner and making sure that you feel comfortable saying, it really hurts when we do it this way, and making sure that it's a position that is comfortable for you and not causing a lot of pain. If you start to have more pain, like you've not had pain before and all of a sudden having pain, or if you start having bleeding after intercourse, you want to make sure you let your provider know, because that can sometimes be a sign that your cancer is coming back too. Not usually with ovarian cancer, but other cancers, but definitely make sure that you're notifying them of that. There's also some really good referrals like psychology where they kind of focus more on the mental part of it too. Sometimes after having a hysterectomy or going through chemo or just going through this diagnosis in general with being on the treatment can really impact the mental component of like how you feel about having intercourse or your partner. And so I think sometimes going through the counseling for that, and you can even bring your partner with you and talking about it really helps.
Great. And then this person is asking about some other ways to deal with sleep issues other than like strong sleeping pills.
Number one is you want to make sure that you have like a good sleep hygiene. So we recommend going to bed around the same time every night so that your body is kind of on a schedule. You also want to make sure you're not sleeping more than 7 hours at a time at night. Some people are oversleeping and then have like a bad sleep schedule. And also avoid napping too much during the day. And I know that's hard with going through like cancer treatment. Sometimes you need the nap to get through the day, but try to do it earlier in the day and maybe like set an alarm and don't just nap until you wake up, but take a shorter nap so that you're able to fall asleep that night. Only use your bedroom for sleep and sex. So you don't want to be in there watching TV, reading books all day, taking your naps during the day in there. Your mind needs to kind of correlate when you go to bed to going to bed and falling asleep. and then kind of having a routine. So every night, you brush your teeth, wash your face, you read a book and then go to bed or whatever it is, but kind of having that same routine every day can really help as well. Exercise early in the day, not before bedtime, because that gets your endorphins going and then sometimes it's hard to fall asleep. And then also avoid drinking alcohol to make you sleep, because that's really bad for sleep. It like helps you fall asleep, but then it wakes you up frequently throughout the night. You also don't want to go to bed too full or too hungry. I know a lot of people, want to snack before bed, and that's fine, but you just want to make sure you're not eating too heavy, but you also want to make sure you're not going to bed starving. And then as far as medications, there's some over the counter like melatonin that can help. It tends to be pretty well tolerated and doesn't give you that drowsy hungover feeling the next day, but it can cause pretty vivid dreams is what patients typically report. But it does seem to be a little bit more natural than some of these stronger sleep medications.
Great. And then we have another anemia question. So this person is saying that their hemoglobin is low, but their iron labs are normal. Do you have any other suggestions to help with their anemia?
So that's an indication that it's just the chemotherapy causing the drop in the red blood cells, and you don't have any type of insufficient iron. And so that's good that they did the iron studies. It's good that it's not causing any impact on the actual iron. It's just the chemotherapy destructing those red blood cells, which is a common side effect. The iron supplement is a start. You can take that daily. There's not a great diet that just kind of boosts those red blood cells, but some people swear by certain foods increasing the red blood cells. But keeping a close eye on it. I also know it's kind of hard to hear and to understand, but when you're getting chemotherapy or a cancer patient, your hemoglobin just isn't probably going to be the normal range. And so as oncologists, we keep an eye on it. We'll let you know if it's dangerously low or to a point we need to intervene, but also just kind of understanding that while getting treatment and for a while after finishing treatment, because it can last for a while, that your hemoglobin just might not be in normal value, but our goal is to keep it high enough to where it's safe.
Great. And so it looks like we only have a couple more minutes, so I'm trying to get through a few more questions. So is age-related macular degeneration related to chemotherapy? Is there any connection?
I don't think there's a direct connection that I'm aware of, but we've definitely found, we've come a long way with cancer treatment options. It used to be patients with ovarian cancer had a very, poor prognosis, didn't live very long. And now we're giving chemotherapy for much longer. And so what we're seeing is having more long-term effects on vision, on dental work, all of those things. And it used to be, we're finding more and more out because we're giving chemotherapy longer. And we do think that it could potentially be causing things like macular degeneration or problems with teeth, bone health, things like that. And so we're still studying it. I'm not aware of a direct correlation, but they definitely could be related. And so we usually recommend there's some vision changes while receiving chemotherapy. So I don't usually recommend getting a big change in your prescription eyeglasses while actively getting treatment, but waiting until you're finished with treatment, seeing the eye care provider and see if there have been long-term changes to the eyes.
Okay, great. All right. It looks, okay. So what do you suggest for proteinuria?
There's some evidence that ACE inhibitor, which is like a most common one that you guys probably are aware of, is lisinopril. It's a blood pressure medication, but it can help with the protein in your urine. The bevacizumab can cause protein in your urine. It's something that we check baseline and then prior to your bevacizumab infusions. If that lab value that urine becomes too high, then we usually refer to a neurologist and they can kind of help manage it. But there's nothing you can necessarily do to prevent it. There's nothing you can do on your own to stop it from happening. It's the chemotherapy or the bevacizumab that we're giving that's causing it. So it's keeping an eye on it, make sure it's not getting too high. Sometimes we have to stop treatment with bevacizumab if it is high, but sometimes doing a low dose of the lisinopril can help prevent that from getting higher too. And then the nephrologists usually have some recommendations as well. And then keeping your blood pressure well controlled also can help decrease the urine protein.
Great. Well, I think that we, don't have any time for any more questions, but we covered a lot of ground. Thank you, Courtney, for such an informative program and answering so many questions. And thank you to all of you who participated today and submitted these questions. We hope that this webinar was helpful to you and gives you resources to better manage your treatment side effects. Please make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. As you can see, these are some of our upcoming programs. And we also ask that you please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be sent in a follow-up email. All surveys are anonymous, and we really look at that feedback and use that to improve our programming. So please fill that out. And with that, this concludes today's webinar. So thank you again, Courtney, and thank you to all of you who joined us today.
Thank you, guys.